Thank you, Stephanie, for that introduction. We are thrilled to have you all here to share the R4P framework and all that it has to offer the field. The R4P framework is born from the work that Doctors Diane Rowley and Vijaya Hogan have done and are doing in the maternal and infant health field. The existing disparities that result in Black infants being twice as likely to die before reaching their first birthday, twice as likely to be born premature, twice as likely to be born low birth weight than their white counterparts are disparities that are avoidable. And Doctors Rowley and Hogan recognized that there wasn't an existing framework in the field that captured the multidimensional causalities that come into play with racial inequities that factored in individual and social and structural determinants, racism, and many of the other factors that influence health across the life course. And so they created R4P. The R4P framework is informed by the dimensionality framework. Dimensionality is an approach to understanding health inequities. It is an approach that factors in intersectionality, which talks about multiple identities and the different axes of oppression that creates, critical race theory, which factors in structural racism and how it interacts and impedes upon our lives, and also factors in dimensions of time, both past, present, and future, with concepts such as the life course and historical trauma, and research from the fields of developmental health as well. So while you have dimensionality as this approach to understanding the health inequities and understanding the problem that exists, you then also have R4P, which is the organizing system for identifying and reversing the unfair and avoidable consequences that exist in our society, and allows us to enter that solution space. So explaining the design of R4P. R4P is a health equity framework. It consists of 5 components: remove, repair, remediate, restructure, and provide. The first component of R4P is remove. And here is where you're focusing on removing power imbalances that result from racism, classism, sexism, many of the isms that structure and shape our society, the forces that are adverse to our health and health maintenance and health seeking, and that are embedded in most societal institutions. So this component relates specifically to those forces. And you might ask questions such as, where are these forces operating here? It can involve structural as well as institutional change. And can also involve a personal assessment on an individual level of how implicit bias based on race or ethnicity, SES or gender might exist within the professional, the intervention, or the policy. The ability of a researcher or practitioner to be self-reflective about their own tendencies to participate in these systems is essential for the remove component. It also allows for a deeper and more thorough analysis of why disparate populations are in their current situations in the first place. So it really allows you to get into critically analyzing why the health inequities that we have today exist, while factoring in the power imbalances that exist in our society. For those that are visual learners, such as myself, another way to think about it is thinking about taking away those forces on not just an individual level, but on a systems level, a community level, a policy level, all the different levels across the ecological perspective that impede upon one's health. So removing those forces, that's what remove is about. Then we get to the second component of R4P, which is repair. This component is focused on taking a look at the past, taking a look at how historical risk is embedded in our current physiological and social structures. It's taking a look at how historical trauma affects not just individuals, but generations. So repair takes history, the impact that history has had strongly into effect, and how it's affected current health inequities. Now, this is very different from most frameworks, as many health interventions are often ahistorical. So, focusing on present statistics or present factors at play, modern access to modern devices, or other elements such as that. Whereas repair really examines how we can connect events that have happened in the past to current risk today. This often results in asking critical questions, such as what past exposures produced damage that impact the current ability of a population to access healthcare, maintain healthy behaviors, be able to access their health provider, have health insurance, have health across generations, have health within their family members. So really examining that damage from the past. And there are many laws on a policy level that influence the ability for there to be equitable outcomes across populations, and that stem from the history that we have surrounding racism in this country. So another way to think of repair when you think about damaging the past, as you look at this visual, you'll see here that there's been many scars across this heart that's been broken. You know, you have the lightning bolt scar down the middle that needed to be repaired. You have the patch on the side that needed stitches to be sewn up, and you have this Band-Aid across the middle as well. And so there are multiple time periods, multiple policies and laws, multiple points across the time span that populations have existed in the US that might require a further examination and looking at how we might repair the risk that results from those historical traumas that occurred. The third component of R4P is remediate. This is meant to happen while we wait for structural changes to be completed. It's about reducing exposure to negative context. So reducing your exposure to risks, those risk factors. This is where you ask yourself, or an interventionist might ask themselves, what conditions in the organization do disparate populations need to be protected from? Okay, so what are the conditions that are creating risk factors for these populations? Again, this is meant to happen until restructuring occurs and the insult is removed. So it's not meant to be a standalone intervention. It should only occur alongside restructuring of a system or a policy or a program to help reduce inequities. It's meant to examine how the social context continues to be a source of adverse exposures currently, and how at-risk populations need to be buffered from these exposures to reduce that vulnerability. One way to think about remediate is in the immediate moment, how are you going to take away those risks that impede upon someone's health? So that might look like you have a stormy, rainy day and you have several holes in your roof, and you immediately need to go up there and put a tarp on to prevent the house from flooding. That's what remediate looks like. In that immediate moment, you're trying to prevent all this water coming through to that house. Then you have the fourth R, restructure. So as we talked about earlier with remediate, it shouldn't be a standalone intervention. It should happen alongside restructuring. So here we are at restructure, where you're focused on changing policies, institutions, organizations, examining those societal structures where we live, work, and play, which we know can function inequitably. And they continue to expose populations to adverse conditions and result in producing risk. Restructure requires researchers, practitioners to assess, examine the structures in their organizations, our systems that maintain systematic exclusion of disparate populations, while simultaneously being able to provide advantage or privilege to others, and which also needs to be acknowledged. This step requires a critical examination examination of how the policies, the procedures, the culture, and the resources of an organization, an institution, a program perpetuate exclusion, even in the presence of good intentioned researchers and practitioners. When you're thinking about restructure, you might think of a puzzle with many different pieces that look different. You might need multiple team members, some people to step back and have that global look, and some people to really be in there, inside the puzzle, working from within. You might need a ladder to reach certain steps of that puzzle. You might have pieces that don't seem like they fit, but you're trying to figure out a new way to create that puzzle, a new system. You're trying to change the way things are operating because clearly they're inequitable and resulting in adverse health outcomes for some while promoting healthier outcomes for others. They're resulting in inequities. And so you're wanting to change that system, the policy, the program, the institution, the organization, restructure things. And so we've arrived at the P, the provide component of R4P framework. This is about providing health education and medical care, along with resources and environmental support, evidence-based practice, something that we focus on a lot in public health. But it's also about making sure that those services that we're providing are planned out in a way and delivered in a way where the resources and the environmental supports are easily attainable for disparate populations, where we're factoring in other structural and social determinants of health that might be at play that impede certain populations from accessing the health education and medical care and evidence-based practice that we know can work to improve health. So we need to be sure that what we're providing is culturally, economically feasible health education and medical care, along with social support, environmental support, so that it becomes that the easiest option for people to choose and sustain health promoting actions are evidence-based practices, and that people are able to access them, choose them, use them, and benefit from them. The emphasis with the provide component of R4P is to think critically about how the realities of racism, classism, sexism can be considered in service delivery by institutions. So to create these evidence-based practice programs and care that we're providing with the context of how the power imbalances of our society might impede certain populations from being able to attain what we're providing. So we have remove, where we're focused on removing these power imbalances that impede upon people being able to access certain healthy promoting behaviors or health programs or that we're offering in the field. It can operate at an individual level as well as a societal level. We have repair, where we're focused on taking a look at the past, not operating in a way that's ahistorical. We have remediate, we're focused on reducing that exposure to negative context or risk reduction. And this is meant to happen while we wait for those structural changes to happen as well. It is not a standalone intervention. Which brings us to restructure, where we're focused on changing policies and institutions and organizations, changing how societal structures can function inequitably. And then provide, we're focused on making sure that we're considering these power imbalances and this historical trauma and the risks that people are exposed to and the policy and institutions and organizations that need to be restructured while we're creating health education and medical care and resources and environmental support using evidence-based practice. With provide, we're trying to make sure that what we're providing is accessible by all, especially for those that are considered to be a part of populations that bear the brunt of inequities, health inequities in our society. So again, with remove, you're removing those imbalances, you're repairing that heart with repair, you're putting the tarp over the roof with remediate in that very moment, introducing that risk, preventing that flooding. And with restructure, you have that puzzle you're trying to figure out to change that policy system and organization. And it oftentimes might take a team, take a step back, take a look at what's going on there, be critical. All of these, it's important to have a critical examination of what's going on and what it's going to take to improve while factoring in the remove, repair, remediate, and restructure. And then you provide those protective factors. You provide while considering all of these power imbalances and the impact that history has on current risk. And you consider the life course of those populations. You bring in that time dimension as well. So all of this can seem like a lot. All of this can seem like being very having a very critical examination of current inequities today, how history has played a role. And so I'm going to now give an example of the R4P framework being applied to give you all a better understanding of how you might actually use this framework. And so across the board, the R4P framework can be used for program planning. It can be used to evaluate a program. It can be used for a researcher as a framework for research. And also these components are not standalone interventions. They're also not linear in that they don't have to happen in a certain order. And they're all essential for this framework to operate effectively. And so this example that I'm about to show is actually an example from an undergraduate class focused on maternal and child health inequities, one that I had the pleasure of teaching. And they were tasked with using the R4P framework in this class to create their own program that was designed to address inequities. And so this wonderful group decided to use the R4P framework to create a program focused on breastfeeding inequities. And so as a reminder, R4P requires organizations to remove that removal of racism or any other power imbalances at play. And so these students decided their main remove component was going to be equity training to remove biases of physicians and how the physicians might interact with populations within the hospital that they're providing care. So equity training consisting of a program around requiring physicians to go to equity training or other practitioners as well. So that was how they decided to incorporate the removal component of R4P. Next, you have repair, which focuses on that historical look. So looking back in history. And so these students decided to incorporate discussions during prenatal care that's centered around breastfeeding and the existing historical impacts from that. So in the class, we often talked about, breastfeeding in the historical trend of breastfeeding, when different populations breastfed. And so these students decided to take a look to incorporate a historical analysis of breastfeeding during prenatal care. So next is the remediate step, where it focuses on those current exposures. So think back to that tarp that's going over the roof. And so these students decided that they would have a postpartum support group for breastfeeding women and create that continuity of care. In the class, we often talked about postpartum support being something that is lacking after giving birth. So they focus on that continuity of care to remediate those current exposures and create a postpartum support group, specifically having it focusing on breastfeeding. Then you have restructure. And since we know that the remediate step shouldn't happen as a standalone intervention, they have the restructure component where they decided to incorporate concepts such as paid maternity leave, as well as a more systems level approach of hospital grants created for baby-friendly initiatives that promote breastfeeding. So that was how they decided to incorporate the restructure component. And then with provide, the focus is on providing services that address those cultural and economic needs, that focus on the realities of our society and how it impacts current health trajectories, not just providing services without taking that into account. And so they decided for the provide component that they would actively target hospitals with worse outcomes in breastfeeding. So really factoring in the existing all the different existing components that impede on health, and making sure to provide those services specifically to populations that are accessing hospitals that have the worst outcomes in breastfeeding. Making sure that this program, with equity training for physicians and discussions during prenatal care centered around the historical legacies that are intertwined with breastfeeding, that factored in a postpartum support group for breastfeeding women with the continuity, continuing that care, but also providing that social support. And then also that factored in paid maternity leave, as well as hospital grants and baby-friendly initiatives, that they were bringing this program with all these different components in it across the restructure, remove, repair, and remediate to a hospital, to a city that actually has worse outcomes in breastfeeding, so that they are making these services, this program, attainable for those disparate populations. Additionally, they decided they would hire Black women to facilitate this program, which also gets at the economic needs in that community, creates jobs, creates partnership within the community where you're going and you're seeing someone who looks like you. So that's how they incorporated the provide component, by actively targeting hospitals with worse outcomes in breastfeeding so that those populations could benefit from this program, and then also hiring Black women specifically to facilitate this program. So this, again, these were undergraduate students who used the R4P framework in a class that was focused on inequities, and created this program focused on breastfeeding inequities in the Black community. It is vital to note that when using R4P, it is important to be in dialogue with community. You can use the R4P principles as lines of inquiry to start the dialogue to get deeper into root causes, conditions, and solutions. R4P serves as a way to decolonize thinking and get people to analyze from a space grounded in social and societal realities, and allows generation of solutions that fit those realities. Acknowledging and understanding the factors in play for each domain and trying to address as many of them as possible is essential, while also acknowledging factors that you are unable to address at that time. If you bring light to all of the deeper issues, someone else may be able to address them even if you can't. We know in public health and other fields, it is not possible for us to address everything. Naming and acknowledging all of these factors, both the ones that were addressed and were not addressed, will create room for others to pick up where you left off and increase the collective impact, and allows us to go deeper towards the roots of inequities. So R4P helps you to dive deeper, to examine the forces that are keeping the situation the same, to better understand, investigate, and ask, what are the forces that exist at a structural level that are causing harm or that result in inaction in the face of need? What forces are perpetuating racism? Where is racism operating? What forces are allowing past negative exposure to persist? Or what forces from the past, even if now gone, still have influence on current conditions? What forces are creating current risk? And finally, what are some of the programs, interventions, and services that are failing to include the community and that fail to consider the effects of racism, classism, and gender-specific needs and the intersections of these? Again, doing all of this in partnership with community is a vital component of this process. So now that we've covered the design of R4P, we've talked about how you might apply the 5 components of R4P on a variety of levels. And I showed you this example from this undergraduate student class that used R4P to create a program. I'm also now going to show you how you might assess an organization, a program, an institution's ability, or even a research design's ability to get at the different components that are within the R4P framework. So you would do this by using the R4P HRIME scale. We know that R4P can be used as this framework for organizations to work with marginalized communities in order to assess and plan for racial equity. but it can also be used as an evaluation of equity actions for a program, for research, or for an institution. So this is the HRIME, the Hogan-Rowley Institutional Measure of Equity. It's a scoring guide that ranges from 6 all the way to -6. And you'll see across the numbers, across this range in this scoring guide, actions that are neutral, actions that promote equity, and actions that are aggressive when it comes to equity. So when we talk about neutral on the HRIME scoring guide, we're at 0, where there's no mention of domain factors and no evidence of meaningful action to address inequities that are occurring. So no acknowledgement, no evidence, no mention of any of the factors across the 5 domains of R4P. When you get to 1, there's evidence of at least some sort of reference and acknowledgements of needs that are in the domain. When you're around 2, institutions might accept that there are actions that are occurring that can be defined as being either equitable or inequitable within a population. When you get to 3, there are actions to address factors that are considered to be an integral aspect of institutional or programmatic goals and objectives. So you're starting to see it incorporated more within an institution. And then you get to 4, these actions have been fully developed in collaboration with communities and are fully integrated into permanent institutional structures and activities. 5, these actions, again, are working with communities, and the activities have been happening for greater than 3 consecutive years. So now you're starting to get into the sustainability of the actions. And then when you reach 6, these are firmly institutionalized practices that you're seeing that are influenced by working in collaboration with communities as well, that are working towards equity, creating synergy, factoring in multiple levels of the ecological perspective, as well as multiple domains across the multiple factors that come up within the domains of R4P as well, and are having a larger impact on equity within that community. So obviously this is the direction that we'd like to go in. We'd like to go from 0 to 6. We'd like to get to a point where you have people referencing the different factors that come across the domains in R4P that impede health and perpetuate health inequities, and acknowledging them, into accepting them and reflecting on where they might be occurring in that institution. And then when you start to get to 3 and up, actually moving beyond referencing them and accepting them into creating action. So moving from acceptance to action around those factors. And then as you get further up the scale to 6, you're talking about taking that action and institutionalizing it, embedding it within the way that organization, that institution, that policy is actually operating. And then getting into sustainability when we talk about 3 consecutive years or more, and incorporating the community as well. Now, the other direction to head into is going to -6. So when you're at -1, you're talking about there being an active denial of existence of factors that we see across the R4P domains as critical to examine for health inequities. Even perhaps a justification of institutional inaction in addressing different factors. -2, you're seeing that populations that experience health disparities inequitably are being targeted, and that implementation is not authentically addressing community needs or protecting community assets or exhibiting respect on an individual level as well. When we get to -3, we're talking about that continual targeting of interventions that are demonstrated to address need, but there being no evidence to support the relevance of issues and needs in that population. So you're talking about trying to create interventions without any sort of understanding of the factors that come across the remove domain, the remediate domain, and the restructure domain, or the repair domain. When we get to -4, again, we're thinking about those interventions that are being implemented and finding that they're actually resulting in increased burden on participants, that they're resulting in diminishing resources that are needed. When we get to -5 and -6, we're not just talking about, active denial, targeting populations, but actually resulting in increased burden. We're talking about actual actions that consist of manipulation, victim reversal, and removal of protective supports and/or developments of adverse health outcomes resulting from that institution being at play or that organization being present in the community or that program existing that's targeted that population. So active actions of manipulation resulting in those increased burdens. When it gets to -6, that is where you see an organization that is embracing regressive actions and creating actual momentum away from equity. So that is how you use the HRIME scoring guide across the R4P domains. So if you were using this as an evaluation tool, you would have factors that fall into the remove domain, the remediate domain, the restructure domain, and the repair domain. So you think about removing that mask, putting the tarp over the roof, bandaging that heart several times that has been broken in the past, and taking a look at that puzzle. You have those different factors coming across that domain, and you might enter an organization or institution trying to evaluate how it's hitting those factors within that domain, how it's covering, examinations of historical legacy or policies or risk reduction or power imbalances, right? And so you'll use this scoring guide to assess that. You'll take a look at the HRIME scoring guide and see, are there simply no mention of domain factors, or are they addressing factors and they have it institutionalized and they're working with communities and they've been doing it for several years? Or are they actively embracing regressive actions? Are they increasing the burden with the community and targeting disparate populations and creating more or increased health inequity within that community? That is how you would use the HRIME scoring guide while evaluating equity actions across the domains of the R4P and the many factors that fall along those domains. So we've looked at the design, the application, and the assessment using the R4P framework and the HRIME scoring guide. With the design, again, you're focused on the removal of that mask, the repair of that heart that has been broken several times, the putting the tarp over the roof to reduce that risk in the moment, which should never be a standalone intervention, as you're also working on figuring out that puzzle, that system, that institution, that organization, and how to restructure it so that you can make sure that you are providing evidence-based practices and actually making it so that it's accessible to the populations who need it. And you're considering many of those factors that fall across the remove, repair, remediate, and restructure domains of the framework. When you're applying this framework, you can apply it to research, you can apply it to a program, you can apply it to an evaluation. And when you're applying it, you're considering how can the examination of power imbalances result in a programmatic component? How can we look at repair and create a programmatic component from that? Same with remediate, restructure, and provide. And if you're using R4P, you need to also be able to use the HRIME scoring guide to assess a program or a policy or institution or an organization. And you can use the HRIME scoring guide to assess an organization that wasn't used with R4P as well. It's a scoring guide that goes from -6 and includes 0 in the middle as that neutral zone. And you can examine, are we moving towards promoting equity in sustainable fashion for where it's integrated within the community and it's institutionalized practices, or are we doing things that are resulting in regressive actions that are actually increasing burden on populations that experience inequities. And so another important thing to say about R4P is that it is a framework that can be used within the field of public health, across the multiple avenues that we have. So it can be used within research, it can be used for evaluation, it can be used to plan a program. As a researcher, if you want to use the R4P framework, you can create interviews, you can create questions on your interview guide that factor in the different critical questions you might ask and remove, or repair, remediate, or structure. So that's another way to think about using it too. As you're collecting data, you can use it as a framework to guide how you analyze that data. So it can be used in multiple applications because of this design of this unique framework. And of course, you need to assess how you've applied it, and that's where the HRIME scoring guide comes into play as well. We know health inequities are extremely complex, which is why they've persisted for generations and generations. We understand that addressing social determinants, structural determinants is absolutely necessary, but it is insufficient for achieving health equity. We also know that employing evidence-based practice is necessary, but it is also insufficient alone for achieving health equity. The R4P framework across its 5 domains is designed to translate that complex causality that we know exists with health inequities into a public health equity planning, assessment, evaluation, and research tool. And we are so excited and thrilled that we've had the opportunity to share this framework with you all today, and that you've joined us for this webinar on R4P. We are so grateful, and we hope that you'll stick around for the Q&A session with the creators of the R4P framework, Drs. Diane Rowley and Vijaya Hogan. Thank you so much.